Welcome back to the Masterclass, everyone. We're diving right into Part 92 today. Last time, in Part 91, we unpacked the medical side of MDC08, but today we are taking on a massive, highly scrutinized beast, the Advanced Surgical DRG Deep Dive for orthopedic surgery and major joint replacements. Before we get into the heavy lifting of surgical grouping, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Mastering orthopedic DRGs is absolutely crucial, so let's get this out to everyone who needs it. All right, here's our roadmap for today. We're looking at an intro to orthopedic surgery, the MDC08 surgical hierarchy, high-volume musculoskeletal DRGs, precision coding and audits, and finally, a summary and what to expect in our next lesson.
Section 1. Intro to Orthopedic Surgery. So, Major Diagnostic Category 08. This whole category revolves entirely around diseases and disorders of the musculoskeletal system and connective tissue. We're talking the structural foundation, bones, joints, muscles, and all the connective tissues holding them together. This is where elective joint reconstructions, trauma fracture fixations, spine surgeries, and soft tissue procedures live. And let me tell you, getting these codes right is the literal difference between securing appropriate reimbursement and facing a catastrophic payer denial. The financial stakes are huge here.
Moving on to Section 2, the MDC08 surgical hierarchy.
Okay, let's talk about the golden rule of DRG assignment. Every single admission starts with a principal diagnosis, which naturally funnels the case straight into a medical split. But the very second a qualifying operating room procedure is performed, boom, it triggers a surgical split. That trip to the OR completely overrides your medical diagnosis and changes your entire DRG pathway. And why does this matter? Because surgical DRGs carry significantly higher relative weights, reflecting the massive hospital resources required for surgery.
Let's look at how this plays out in the real world. Say a patient comes in for an incision and drainage of an unspecified abscess. Because that site is unspecified, ICD-10 PCS rules push the case into a medical DRG for infections, specifically MSDRG 455. But you're a sharp coder or CDI specialist, right? You queried a clinician. They clarify, actually this is acute osteomyelitis of the right femur. Suddenly that basic IND is confirmed as a definitive procedure on a highly specific anatomical site. The result? The whole case shifts into surgical MSDRG 486, which is major hip and femur procedures without CC or MCC. Just by capturing that exact anatomical site, you turned a basic medical infection DRG into a much higher weighted surgical one. That is the power of specificity.
Section 3. High-volume musculoskeletal DRGs. In ICD-10 PCS, procedures are defined by their root operation. When we're talking about major joint procedures, the absolute star of the show is replacement, which is represented by character R. By definition, this means putting in or on biological or synthetic material that physically takes the place and/or function of all or a portion of a body part. And this brilliantly illustrates a key coding rule you have to remember. The replacement root operation inherently includes taking out the original body part. You never code the removal separately when you're putting a brand new joint in. It's an all-in-one package.
Let's break down code 0SC0J9, which is the replacement of a right knee joint with a synthetic substitute via an open approach. Every single character in this string has a specific job. For instance, that J tells us it's a synthetic substitute. You have to comb through that operative report to pull out specific device details. Is it uncemented, cemented, ceramic, oxidized zirconium? These tiny details literally dictate whether you land an MSDRG 469 with an MCC or 470 without an MCC. You've got to get it right, especially with all the regulatory shifts of knee and hip arthroplasties moving on and off the inpatient-only list over the years.
Now let's contrast replacement with another massive financial driver, which is fusion, represented by character G. Fusion means joining together portions of an articular body part, rendering it completely immobile. You are literally locking a joint in place using fixation devices, bone grafts, or other means. What you've got to keep in mind here is that only a limited range of procedures actually use this root operation because fusion is exclusively performed on joints.
Here's exactly how that logic applies to spine surgery. Take a code like 0SG00ZZ, representing a lumbar spinal fusion posterior approach with an autologous bone graft. You have to verify what kind of device the surgeon used. Was it an autologous graft, meaning bone harvested from the patient's own body? Was it a synthetic device, like an interbody cage? What about the instrumentation? Also be hypervigilant about the approach, anterior versus posterior.
Getting this wrong drastically shifts your MSDRG grouping into entirely different families, like 453 to 455 or 456 to 460.
Section 4. Precision Coding and Audits.
Think of the 7-character ICD-10 PCS code structure like a giant puzzle. Let's look at 0SRB0JZ, a left hip replacement. Every single position, from the S for lower joints all the way down to the J for a synthetic device, unlocks a piece of the surgical story. Your documentation must explicitly support all 7 characters. This is absolutely crucial when navigating things like comprehensive care for joint replacement or CJR, value-based bundling rules. Payer audits heavily scrutinize these exact character assignments to defend medical necessity, so your 7-character code has to be bulletproof.
And let's not forget, severity of illness is what really dictates your final reimbursement. In post-op orthopedic patients, you need to be hunting for high-yield secondary conditions. We're talking acute post-hemorrhagic anemia that requires blood transfusions, post-op DVT or pulmonary embolisms, surgical site infections, post-op delirium, and acute kidney injury. Capturing these specific comorbidities is exactly what drives your MSDRG severity levels up to an MCC tier. Let's ground all these abstract rules with a clinical case study. Imagine a patient is initially admitted with right calf thrombosis and cellulitis. They're treated medically with IV antibiotics and hyperbaric oxygen therapy. But, unfortunately, their condition deteriorates. The patient ends up undergoing an above-knee amputation, or AKA, performed by the surgeon. Notice how the case just shifted? We transitioned from a strictly medical admission for DVT and cellulitis right into a major surgical grouping.
But here's the catch. What makes this case complex isn't just the amputation itself, it's the entire clinical picture. Our patient has end-stage renal disease, non-insulin diabetes, hypertension, atrial fibrillation, mild congestive heart failure, protein depletion, and anemia. A CDI specialist must aggressively ensure every single one of these conditions is documented and coded. These comorbidities are your armor. They defend the severity of illness against payer audits and help you prove the medical necessity for an inpatient level of care.
Section 5. Summary and Next Lesson. Let's wrap up with some key takeaways you need to memorize. First, ICD-10 PCS is heavily structured and procedure-specific. You absolutely must know the difference between a root operation of replacement versus a revision. Second, always verify the approach, the device, and the laterality to nail down those MSDRG 469 and 470 splits. And third, make sure you sequence the principal procedure first for correct DRG assignment.
So, we've mastered the bones, the joints, and the heavy orthopedic hardware. But how does the coding logic shift when we leave the skeleton behind and focus purely on the surface level? In Part 93, we're going to tackle the Advanced Medical DRG Deep Dive for Major Diagnostic Category 09, exploring skin, subcutaneous tissue, and breast. It requires a totally different mindset, and I honestly can't wait to unpack it with you.
Before we go, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is what keeps this masterclass going. Keep decoding, keep learning, and I'll see you in Part 93.